we also have seen 2 randomized trials, Giorgio, comparing alectinib to crizotinib in the frontline space. Talk to us about the ALEX trial, and give us your thoughts on whether alectinib is poised to be the new frontline option.
Well, we initially saw the study done in Japan that was called J-ALEX. The study was using, compared to the ALEX study that has been presented more recently, a lower dose of alectinib in the comparison with standard doses of crizotinib among the Japanese population. So the first study, the Japanese study, was showing an outstanding superiority for alectinib compared to crizotinib. But considering the ethnicity or the ethnical differences between Asiatic patients and Caucasian patients, a second study was needed, and the second study was the ALEX study. Again, as Benjamin said before, alectinib showed a striking superiority compared to crizotinib in this second study. When you are considering the activity of alectinib and also the minimal toxicity that you are generating with this agent in the ALK translocated patients, I truly believe that alectinib should be a preferred agent. But again, I share with Benjamin the story about the marathon. I truly believe that in the ALK patients, as well as for the EGFR mutant patients, the most important message that should be communicated is that independently from which kind of treatment you are choosing frontline, it's critical to make a rebiopsy at the time of the progression. Why I'm saying that? I'm saying that because in your introduction to this session, and also Benjamin before, we are dealing with multiple agents. And these multiple agents at this time only in cell lines, not in human beings, showed a differential activity based on the type of resistant mutation that has been observed. So it could be that in the real future we are able to tailor. It's not just a matter of sequencing, and sequencing by chance. It means you will start with crizotinib, you are moving to alectinib, and then to brigatinib, and then to orlatinib. That is what, at least in my center, we are doing these days. No? But it could be that increasing the sensitivity of the diagnostic techniques, increasing the amount of rebiopsies that not only us, but also outside of the academic center, patients will receive, we will be able to frame our sequence of treatments in a different way, based and guided by the type of resistant mutation that we saw in the tumors. I know that it's just a dream, but I need to be a dreamer, because otherwise there is no reason to go ahead. So consequently, I truly believe that, even more importantly, that in the context of the EGFR mutants, where there is one mutation, one resistant mutation that is overarching all the others, because we were talking about 60% versus all the others, about T790. In this context, probably we need to learn a little bit more how to sequence all these agents. But it's a matter of fact that any decision that we are making in the clinical practice are always a trade-off between the activity and the toxicity. We learn over time how to manage the toxicity of crizotinib. It's not an issue anymore, because at the beginning we were fearing about a lot of short-term and long-term consequences, including also the interference with the endocrine system, especially in males. But this is something that is not really relevant, because across a learning process, we started managing all this kind of toxicity. But considering, as I said, that we are making the decision, the therapeutic decision, based on this kind of trade-off, I truly believe that alectinib may be a good frontline agent for ALK translocated patients.
So that was an excellent summary of the critical issues that we face about testing, sequencing. I want to bring up the issue of brain metastases. In ALK-positive patients, we know that the disease has a high predilection for brain. And we've seen activity with the crizotinib in the brain. We've seen activity with ceritinib and alectinib. But the second generation drugs seem to have more activity in the brain. So Marina, if you had a patient with brain metastases who has ALK-positive disease, how do you approach the treatment?
So we have to consider that ALK translocated patients have more brain metastases compared with other actionable mutations. So in this kind of patient, this is really a huge problem. And we know that crizotinib, which is a wonderful drug, is not the best drug to be active in the central nervous system. We have results both from all the second generation drugs, because they are almost all active on the central nervous system. But I totally agree with Giorgio that we have to create a balance between toxicity and activity, and alectinib proved several insights on the high activity on brain metastases with a very good tolerability. And I can tell you also the story of a young lady who performed a CT scan after just 20 days after starting alectinib. She was full of brain metastases, and just after 20 days she was cleaned. So the activity is very strong, is very quick, and the safety is wonderful. So compared to ceritinib, I would prefer again alectinib for the treatment of brain metastases. And then for the sequence of the drugs, I totally agree with Benjamin for the problem of the sequence, but I think that we have also to consider that we are far from EGFR mutated the EGFR mutation story, because in ALK inhibitors we have several types of mutations, and they represent just 1/3 of the mechanism of resistance to ALK inhibitors. And it appeared also a wonderful piece of paper by Gaynor suggesting that every drug has a specific mechanism of resistance in the mutation. So I think I totally agree that we have to personalize according with the mutation, but also with the other pathways activated in after the first drug ALK generation. But for sure, with the brain metastases, I think that the first line now can be alectinib.